Warm welcome to all the dear learners to my channel, Microbiology Tutorials by Anshul Kumar. Today I am going to discuss about the topic which is very important, not only from the academic point of view, but also it is helpful in diagnosing some of the very important and clinically significant diseases, if not treated promptly and on time, may prove fatal to the individual. So let's start today's topic. So today the topic is on autoimmunity and autoimmune diseases. Now we know that basically the immune system act against the foreign invasion or substances which are foreign to the host body or cells. But if the immunity start developing against the self or host cells, or we can say that there is a breakdown of self-tolerance of our immune mechanism, it causes autoimmunity, and because of that, even the immune cells start recognizing the self cells as foreign and it starts destroying them. And there are classified based on the types of autoimmune diseases, on the types based on the different type of symptoms or clinical implications which is caused, or the type of cells, organs which it attacks during this such type of autoimmunity. So let's start today's topic. Now, autoimmunity is the type of immune response, as already I have discussed, which is against the self antigens, which is also called as the autoantigens. It is called as autoimmunity, and the disease produced by autoimmunity are called as autoimmune diseases. Classification of autoimmune diseases. So it is classified into organ-specific autoimmune diseases, which means that it involves a single organ, mostly the endocrine glands, and autoantigens may be hormone receptors, for example, thyroid stimulating hormone receptors in hyperthyroidism, insulin receptors in diabetes, then intracellular enzymes, which is example is glutamate decarboxylase in beta cells of pancreas causing diabetes. Then intracellular molecules, example is myelin of central nervous system causing multiple sclerosis. Then comes second type, it is the non-organic or non-organ specific or systemic autoimmune diseases. Here it involves multiple organs, and the causative agents of these non-organ specific or systemic autoimmune diseases are autoantibodies, which are produced against DNA, platelets, RBCs, and antibodies against amino-acyl tRNA synthesis cause poliomyositis, and autoantibody against the basement membrane. It involves lung and kidney. Autoimmune disorders were collectively referred to as connective tissue disorders, though now it is proven that connective tissue is not involved in these diseases, the term is still being used. Epidemiology, if I go through that, so what are different types of epidemiology? So first is the related to the gender, or we can say in which gender it is mostly common. So it is mostly common in women. Exception is ankylosing spondylitis, which is common in young men. then mostly it is prevalent in the age between 15 years to 66 years. Means that from the adolescent to the old ages, it is common. Then it is mostly rare in children except in diabetes mellitus. Then familial incidence is that is the which is the diseases which is transferred from one generation to another, and it is high recurrence in families. Now coming to the genesis of autoimmune diseases. So as I have already told you that it is due to the breakdown of self-tolerance in autoimmune disease brought about by multiple mechanisms. So what are some of the important mechanisms which causes the breakdown of self-tolerance? First is the HLA and MHC genes, that is the human leukocyte antigen and major histocompatibility complex genes. There are many HLA and MHC genes, susceptible genes, which are associated with autoimmune diseases. The exact mechanism is not known. However, the following possibilities have been proposed. MHC genes affect the process of negative selection of T cells, so that the T cells that react with self are allowed to develop and mature. So during the process of development of T cells, it enhances the negative selection of T cells. Means basically during the immune mechanism or the development of the immune system, those cells or those T cells which are active against or can act against the self antigens are removed or eliminated. But the MHC genes, what it does, that it allows the proliferation of such T cells also, which are formed against the self cells. Now, second is the however, there are several non-MHC loci and also known as be associated with autoimmune diseases. For example, is the systemic lupus erythematosus and type 1 diabetes mellitus. So here we can say that there are also in comparison or in addition to the MHC gene, there are also several non-MHC loci present on the chromosomes, so which are also related to the autoimmune diseases. Best example is the SLE and type 1 diabetes mellitus. Next is the mutation. Most important mutations of several of immune regulatory protein genes, that is the AIRE protein gene, causes failure of expression of many peripheral self-antigens in the thymus for self-recognition by T cells. Next is the mutation of FAS gene. This affects the fast-mediated apoptosis. Thus, the T cell that reacts with self is not eliminated. Then mutation of CTLA4 gene. Then here what has normally CTLA4 acts as a co-stimulatory signal and makes T cells non-reactive or energetic. Mutated CTLA4 fails to act as co-stimulator when the T cells react with the cell. Then mutation of FOXP3 gene. Regulatory T cells which suppress self-reactive T cells need a FOXP3 transcription factor for its development and functioning. Thus, a mutation in FOXP3 causes failure of function of these regulatory T cells, leading to autoimmunity. Example is the immune dysregulatory endocrinopathy and enteropathy and X-linked diseases in human beings, which is also known as the IPEX diseases. Third is the molecular mimicry. Some of the microbial agents express antigens which have same amino acid sequence as cell protein. That is, it mimics the self antigens. Thus, the microbial agent may trigger activation of self-reactive lymphocytes. This is called as molecular mimicry. Example is rheumatic heart disease. The streptococcal protein has similar structure to myocardial protein, which is also the same process known as the molecular mimicry, and thus antibody against streptococcal protein cross-react with myocardium causing myocarditis. Fourth is the epitope spreading. Once an autoimmune disease has started, it causes tissue damage and inflammation. Thus, further leads to exposure of antigenic epitopic sites of self proteins which are otherwise not exposed to the immune system, hidden from the immune system. Since these antigens sites were not present in the time of development of immune tolerance, they are not taken as non-self and the lymphocytes get activated. The activated lymphocytes further damage and cause further exposure to of epitopic sites and further lymphocytic activation. Thus, a spiraling effect starts and activation of newer autoreactive lymphocytes. This process is called epitope spreading. This process is responsible for progression and chronicity of the autoimmune diseases. Upregulation of co-stimulators. Microbial infections may upregulate the co-stimulator, that is B7-1 and B7-2. This may cause activation of self-antigens presenting lymphocytes, which were made energetic, non-reactive during the development of immune tolerance. This may lead to autoimmunity. Six is the release of sequestered antigens. Any self-antigen which is sequestered from the blood circulation and not even by T cells during development of immune tolerance is not accepted as self. Thus, exposure of such self tissue will result in autoimmunity. For example, is the vasectomy and testicular trauma. The sperm antigens are released into the blood causing autoimmunity. Or else, and ophthalmic injury, lens protein from injured eye may be released into the blood causing autoimmunity and multiple sclerosis. Myelin basic protein is sequestered by blood-brain barrier. When this gets released in intersystemic circulation, it causes autoimmune multiple sclerosis. So we can say that usually that the sperm antigens and the protein present in the eyes are usually not exposed to the blood circulation or they are hidden. But during any injury, when they are exposed, so autoantibodies are formed against and there is a spiraling reactions. So overall, we can say here that these are some of the important factors where the immune systems gets activated against the self antigens. And these are some of the important mechanisms through which autoimmunity develops in the body. Now coming to the, so this is the mechanism which we discussed here. Now coming to the some of the important autoimmune diseases. So the most important autoimmune disease first is the systemic lupus erythematosus. So what is systemic lupus erythematosus? In short, we also say it as an SLE. So it is an autoimmune disease characterized by production of multiple autoantibodies affecting multiple organs. So there are not a single type of autoantibodies produced, but there are multiple types of autoantibodies are produced here, which we will see later in the slide. So here, usually the incidence which takes place here is 1 in 2,500 population. Means that in 2,500 persons, one is affected. Then sex ratio, mostly commonly it is found in females between age 20 to 30 years. 90% of patients are females. In children, SLE is 3 times common. In females, is three times common in females. SLE in males are generally milder than in females. Race common in African American women and age commonly in second and third decade, but may be at any age. Such that in children, SLE is 3 times common in females. Now, coming to the causative agents or etiology, still unknown. However, the basic defect in SLE is a breakdown of self-tolerance. This breakdown of self-tolerance leads to formation of a large number of antibodies or autoantibodies against one's own cellular components. It may be both cytoplasmic and nuclear components. The various cellular components and their autoantibodies are cellular components are DNA, histones, then nuclear ribonucleoprotein particles, which is also known as Smith antigen and nuclear antigens. So here, basically the important antibodies which are formed is the anti-dsDNA, then anti-histone antibody, anti-SM, and anti-nuclear antibody. So these are some of the important autoantibodies which are formed during the systemic lupus erythematosus. In addition to that, there are large number of other antibodies which are directed against other cells are also forming SLE. Some of the common are that is anti-phospholipid antibody and anti-phospholipid beta-2 glycoprotein complex antibody. Other than the presence of a variety of antibodies, we know very little the mechanism that produce them. However, few factors are implicated for procedure of antibodies. These are genetic factors, environmental factors, and immunological factors. So we will see what are some of the important factors which are responsible. So genetic factors, if we see here, so genetic makeup of an individual regulates the formation of autoantibodies. Following facts prove this. Monozygotic twins of SLE patient also suffer from SLE, greater than 20% of them. Risk of developing SLE in family members of SLE patient is high. Unaffected first degree relative of SLE patients show autoantibodies and immunological abnormalities associated with HLA-DQ locus with production of double-stranded DNA and SM and anti-phospholipid antibodies. Inherited deficiency of C2, C4, and C1q. This deficiency causes lack of removal of circulating immune complex by phagocytes, loss of cell tolerance by B cells, failure of clearance of apoptotic cells. It is nuclear content may induce immune response. Environmental factors, which are multiple environmental factors, they are known as to induce SLE are the drugs, that is D-penicillinase, hydralazine, and prokinamide, which induces antibody formation, returns to normal on drug withdrawal. Then ultraviolet light produces interleukin 1 from keratinocytes, which induces immune system by possibly activating T and B cells. Sex hormones. These probably explains female predominance and also flare up during menses and pregnancies. Then coming to the immunological factors. So what are some of the immunological factors which are responsible? That is the B cell hyperactivity. Polyclonal B cell activation has been demonstrated in patients of SLE. However, autoantibodies are not produced from these polyclonally activated B cells. Helper T cells, according to this hypothesis, autoantibodies are produced by helper T cells dependent B cell. Then failure of clearance of apoptotic cells. Thus, the nuclear content of the apoptotic cell induces immune response and dysregulation of cytokines. So these are some of the important immunological factors which are responsible for SLE. Then coming to the genesis of tissue injury. So it is related to the hypersensitivity reactions and that too with type 3 and type 2 hypersensitivity. Type 3 hypersensitivity, here antigen antibody complex mediated hypersensitivity it is called. And here what occurs that there is a DNA and anti-DNA complex deposits on glomeruli and small blood vessels, complement and immunoglobulin deposits on glomeruli. And type 2 is also called as the ADCC, that is antibody dependent cell mediated cytotoxicity. Autoantibodies are produced against RBC, WBCs, and platelets, and it induces ADCC, which promotes their phagocytosis and lysis. And some autoantibodies, specific antibodies against autoantibodies against WBCs, RBCs, and platelets are formed. These antibodies opsonize these cells. These cells are then phagocytosed and damaged. In the process, the nuclei gets exposed, and the ANA anti-nuclear antibodies bind to the exposed nuclei. The nucleus becomes homogeneous, eosinophilic, and lose their chromatin pattern. This is called a hematoxylin body or LE body. The homogeneous material is phagocytosed by neutrophils or macrophages. These are called as LE cells. Then antiphospholipid antibody syndrome. These patients develop antibodies against the phospholipid components of platelets and endothelial cells and clotting factors. This causes antigen-antibody reactions which lead to activation of coagulation pathway resulting in thrombus formation. Clinically, it manifests as cerebral infarction, then ocular ischemia, and then comes the recurrent and spontaneous miscarriages. Antiphospholipid antibodies are, along with the clinical manifestation, is known as primary antiphospholipid antibody syndrome. However, when it is associated with SLE, it is called as secondary antiphospholipid antibody syndrome. Morphological changes. SLE involves multiple organ system. However, the greatest morbidity and mortality is due to renal involvement. Based on morphological changes, different classification of lupus erythematosus have been proposed. Very brief morphological changes in different organs are described below. Predominantly as kidney is mostly affected, that is called as the mesangial lupus glomerulonephritis. Then comes what happens here? There is a mild to moderate increase in number of mesangial cells. Glomerular capillary walls are not involved. Mild clinical manifestations of hematuria or proteinuria. Immunofluorescence microscopy shows that all the glomeruli show deposition of class 1, class 2, class 3, class 4, and class 6 type of glomerulonephritis. Now, next is coming to the focal proliferative glomerulonephritis. Then here what happens? Capillary endothelial cells and mesangial cells proliferation takes place. Neutrophilic infiltration, fibrinoid material deposition, and intracapillary thrombi. Then comes the diffuse proliferative glomerulonephritis. Here there is a diffuse, this designates involvement of all the glomeruli, and each glomerulus is completely involved. Now, mostly immunofluorescence microscopy shows diffuse subendothelial granular deposits of IgG, IgM, and C3. Then next is the membranous glomerulonephritis. Here is the thickening of glomerular capillary wall. So this is mostly the kidney part which is affected in SLE. In addition to that, there is a skin part which shows characteristics butterfly-like skin rashes. Here, what happens? Does characteristics erythematous rash, which involves the bridge of the nose and cheeks. Similar erythematous rashes are also seen on the trunk and extremities. The rashes are induced and accentuated on exposure to sunlight. In addition to that, urticaria, bulle formation, and maculopapular lesions are seen here. Then, in addition to that, histological changes are basal cell degeneration, edema of dermis, inflammation of the vessels, vasculitis, and fibrinoid necrosis of the vessel wall. So these are some of the important histological changes in SLE. Now here, basically, lupus nephritis has been classified as per the Pathological Society ISN IPS 2005. It shows from class 1, class 2, class 3, A by C, C class 4, S2A, G2A, S2A by C, G2A by C, S2C, GC, class 5, and class 6. So this is can be a separate topic on different type of classification and what are some of the important symptoms are present there. Then in immunofluorescence microscopy shows that there is a deposition of IgG and C3 in the dermal epidermal junction. Joints, in joints, there is inflammation of synovium. Cardiovascular, there is a pericardium involvement, myocardium, and in the lungs, there is pulmonary edema, chronic interstitial fibrosis, pleural effusions, and pleural inflammation. In the spleen, there is a thickening and fibrosis of pulmonary arteries. So some of the, it is like, it looks like onion peel cells, onion cut onion cells like in the cases of spleen. Now, clinical picture and complications, if I can show you. So here you can see here the butterfly rash on the face, photosensitivity, that is, it is sensitive to any type of light, then arthralgia, myalgia, autoimmune hemolytic anemia, thrombotic tendency, recurrent abortion, glomerulonephritis, and nephrotic syndrome, chest pain due to pleurisy. Laboratory diagnosis is the demonstration of antibodies, LE cells, LE rosettes, and anti-dsDNA antibodies. So through this picture, you can easily understand that multiple organs are involved, lungs are involved, then joints are here, skin is involved, then mostly which is mostly affected is the renal part, and in the renal also there are different types of SLE. In addition to that, you can see here there are different type of achy joints, chest pain, fatigue, fever, butterfly shaped rash, mouth ulcers, kidney disease, weight loss, joint wrinkles, other skin rashes. And in the next side adjacent, you can see the demonstration of LE cell in the staining through the staining, which represents the anti-DS nuclear antibodies, which is formed against the nucleus of the cells. Next important autoimmune disease is the polyarthritis nodosa. So what is polyarthritis nodosa? It is a disorder characterized by necrotizing inflammation, that is a necrotizing vasculitis of medium or small sized arteries. Positive agents are nature of antigen is not yet known. Circulating immune complex identified. Abnormal deposits of immunoglobulin identified on the affected vessels. Many patients show circulating anti-neutrophil cytoplasmic antibodies, ANCA. Organs involved are kidney, heart, liver, gastrointestinal tract, lung, usually spared. Next is the microscopic complications is the microscopic picture shows all the layers of the vessel wall are infiltrated by neutrophils, eosinophils, and monocytes, which is also known as the transmural inflammation. The vessel wall frequently shows fibrinoid necrosis. The lumen shows thrombus formation. As the lesions become old and the inflammation disappears, the fibrosis of the vessel wall starts. Complications develop, such as the rupture of vessels, infarction of intestine, then intestine, spleen, and lung hemorrhage, glomerulonephritis, ischemic atrophy, and hypertension are some of the important complications of polyarthritis nodosa. Clinical pictures are again arthralgia and abdominal pain are early symptoms, fever, malaise, myalgia, vomiting, and diarrhea. Then subcutaneous nodules, which are tender. Then skin rash, mucosal ulcer, hemoptysis, hematuria, and malaria. Some of the, beg your pardon, that is the melena. This is the some of the important features which are developed during the polyarthritis nodosa. Laboratory feature diagnosis, the final diagnosis is a histological diagnosis of necrotizing arthritis or biopsies of skin lesions, nerve associated with anesthesia, and muscles. Then next important is the scleroderma. What is scleroderma? Scleroderma is an abnormal accumulation of fibrous tissues, sclerosis in the skin and other organs. This is also called as systemic sclerosis. When the sclerosis is limited to skin and subcutaneous tissues, it is called as the morphea. Two types are the diffuse scleroderma and limited scleroderma. Initially, in diffuse scleroderma, when initially they have widespread skin involvement, which rapidly progresses to visceral involvement. Then limited scleroderma is it is limited in the involvement of skin over fingers, forearms, and face. This prognosis is better. However, visceral involvement does occur, but late. Some of the common causative agents are immunological features. Exact etiology are not known, however, abnormal immune mechanism may play a role. Two types of immunological abnormalities have been implicated. One is cellular immunity and humoral immunity. In cellular immunity, the specific antigen which probably causes scleroderma is not yet known. However, this antigen is to be of CD4 plus T lymphocytes, which then accumulates in the skin. The activated CD4 T cells release cytokines. The cytokines recruit and activate inflammatory cells, mast cells, macrophages, and CD8 plus lymphocytes. The inflammatory cells release soluble mediators. The soluble mediators damage the endothelium of microvasculature. This endothelial injury is also indicated by a protease, granzyme A, released by CD8 plus T lymphocytes. Repeated endothelial injury is also indicated by leads to platelet aggregation. Aggregated platelets release PDGF, that is the platelet-derived growth factor, and TGF beta transforming growth factor, which causes periadventitial fibrosis. Injured endothelial cells also release injured endothelial cells also release PDGF and fibroblastic chemo, chemotactic factor. Thus, repeated damage to microvascular endothelium leads to fibrosis and narrowing of the microvasculature. This is the cellular type. Then coming to the humoral, all patients have autoantibodies which are against nuclear antigen called anti-nuclear antibody. These are two types of any anti-Cy70 and anti-centromere antibody. Genetic etiology is that actually two gene has been implicated. However, no specific gene has been found in predisposing. Organ involvement is skin. Then clinical feature is the tightness and texturing of the skin. This starts in the finger and distal regions and of the upper extremities. It then progresses and involves the upper arm, shoulders, neck, and face. The mouth appears small with the skin around the mouth appearing tight and creased, giving the face a masked appearance. Other organs involved are joints, gastrointestinal tract, kidney, lungs, cardiovascular organs. So this is the important features of scleroderma. Next is the rheumatoid arthritis. So what is rheumatoid arthritis? Rheumatoid arthritis is a chronic inflammatory disease which commonly involves multiple small joints bilaterally. Positive agents here is the person who are susceptible to rheumatoid arthritis have HLA-DR4 and HLA-DR1 or both or HLA-DRB1 positivity. These susceptible HLA areas share a common regions of 4 amino acids. These regions present on the T cell is called rheumatoid pocket. These regions are situated adjacent to the T cell receptor region. The exact arthrogenic antigen which binds with the region reduces inflammation of synovium is not known. However, the major inflammatory cell induced are CD4 plus T cells. This T cell inflammation now brings about an autoimmune responses. Next is the Sjogren syndrome. What is Sjogren syndrome? So Sjogren syndrome is a chronic autoimmune disease, disease which is characterized by dry eye, which is also called as keratoconjunctivitis, Sitka, and dry mouth, also called as the xerostomia. Types are primary Sjogren syndrome, Sitka syndrome. This does not occur in any other autoimmune diseases. And next is the secondary Sjogren syndrome. This is mostly associated with other autoimmune diseases such as SLE, rheumatoid arthritis, polymyositis, scleroderma, thyroiditis, and mucoid connective tissue diseases. Positive agents is the autoantibody formation. In genetic conditions, Sjogren syndrome is usually associated with number of HLA alleles, HLA-DB, B8, HLA-DQ-A1, HLA-DQ-B1, HLA-DR3, HLA-DRW, W52. Viral, the exact role of viruses is still not known. However, multiple viruses have been indicated. That is the Epstein-Barr virus, hepatitis C virus, human T-cell, leukemia viruses. Morphology, salivary and lacrimal gland, these are the major target of Sjogren's syndrome. However, other exocrine glands may also be involved. The histological feature shows severe lymphocytic infiltration of periductal and perivascular areas, lymphoid follicles with germinal center formation. Epithelial lining of salivary gland duct shows hyperplasia, sometimes with ductal obstruction. Atrophy fibrosis of the alveoli is a late feature. Cornea involvement of lacrimal gland leads to lack of tears, causing drying of cornea, this causing inflammation, erosion, ulceration, oral mucosa, mucosal atrophy, inflammation, pressure formation, ulceration, lung due to involvement of bronchial glands. The secretions become thick, leading to atelectasis, recurrent infections, and bronchiectasis. Gastrointestinal tract involvement is atrophic gastritis, dysphagia, liver, primary biliary cirrhosis, kidney, tubulointerstitial nephritis, thyroid is the chronic inflammation. Clinical features: age women in 5th to 6th decade, eyes, blurred vision with itching and burning, mouth, dysphagia, loss of taste, dryness, nose, dryness, epistasis, lungs, pneumonitis, repeated bronchitis, diffuse pulmonary fibrosis. Malignant lymphoma, there is a 40 times risk of causing malignant lymphoma. Last one is the polymyositis and dermatomyositis. Polymyositis is a chronic inflammation disease of the skeletal muscle. When it is associated with skin changes, it is called as dermatomyositis. Still, the positive immunity unknown. Autoantibody formation, antinuclear antibody have been detected in the virus Coxsackie virus have been suggested. Morphological changes is severe lymphocytic infiltration of muscle fibers, total muscle degeneration of both type 1 and type 2 fibers. Clinical features: common in middle-aged females, progressive muscle weakness, which starts in the shoulder or neck muscle weakness such as foot pain and tenderness. In dermatomyositis, the upper part of the body shows erythema, there is swelling and purple, is discoloration of the eyelids, other associated with malignancies. In addition to this, there is a mixed connective tissue diseases. The third mixed connective tissue disease is used when there are overlapping features of SLE, rheumatoid arthritis, polymyositis, and systemic sclerosis. Here, high titers of anti-human RNP antibodies diagnostic prognosis is the response to corticosteroids very good. This gives a good long-term prognosis. In addition to that, we can also say one is the IgG4 related diseases. It is a disease characterized by production of IgG4 by plasma cells and lymphocytes, mainly T lymphocytes. It has the following features: affects middle-aged and older men, tissues infiltrated by IgG4, antibody producing plasma cells and lymphocytes, increased serum IgG4, obliterative phlebitis, then storiform fibrosis, and any organ can get involved, such as salivary gland, lungs, kidney, thyroid, aorta, prostate, pericardium, periorbital tissues, lymph node, meninges, biliary tree, breast, and skin. Some of the diseases are renal thyroiditis, then idiopathic retroperitoneal fibrosis, autoimmune pancreatitis, inflammatory pseudotumors, and Nicholas syndrome. So these are some of the important type of autoimmune diseases, which is characterized by different type of symptoms, and also depends upon the type of organs affected. I hope the lecture would have been beneficial for you in learning of autoimmunity. Please do like and subscribe my channel so that it keeps me motivated to bring more topics. If any doubt, you can also write me on the comment section. With this, I conclude today's lecture. Thank you all.